Okay. Assalamualaikum everyone. Myself Dr Atiqa Sohail. I'm resident of gynae department. Today the topic of my presentation is vaginal birth after previous cesarean birth. First, these are few definitions of the terms related to VBAC. First, planned VBAC. Planned VBAC refers to the intended mode of delivery of any woman who has experienced a prior cesarean birth who plans to deliver vaginally rather than by elective repeat cesarean section. Now next, what is successful and unsuccessful planned VBAC? A vaginal delivery, spontaneous or assisted in a woman undergoing planned VBAC indicate a successful VBAC. Delivery by emergency cesarean during the labor indicate an unsuccessful VBAC. But next, uterine rupture. Disruption of the uterine muscles extending to and involving the uterine serosa, or disruption of the uterine muscles with extension to the bladder or the broad ligament. Uterine dehiscence. Disruption of the uterine muscles with intact uterine serosa. Perinatal mortality. Combined number of stillbirths, antepartum, intrapartum and neonatal death between 20 weeks of gestation and 28 days of life per 10,000 live births and stillbirths. Term delivery related perinatal death. Term delivery related perinatal death is defined as the combined number of intrapartum stillbirths, neonatal death per 10,000 live birth and stillbirth at or beyond 37 weeks of gestation. Neonatal respiratory morbidity, combined rate of transient tachypnea of the newborn and respiratory distress syndrome. Now next, what is the recommended schedule of antenatal care for pregnant women with previous cesarean delivery? It includes three things: checklist, shared decision making and documentation. Which women are best suited to have a planned VBAC? Women with singleton pregnancy, cephalic presentation at 37 weeks or beyond, and who had a previous single lower segment cesarean delivery with or without the history of previous vaginal delivery. Now, what are the contraindications to VBAC? VBAC is contraindicated in women with previous uterine rupture or classical cesarean scar, and in women who have other absolute contraindications to vaginal birth like major placenta previa. And in women with complicated uterine scars, caution should be exercised and decision should be made on case-by-case basis by a senior obstetrician with access to the details of previous surgery. Next, can women with 2 or more prior cesarean be offered planned VBAC? Women who had 2 or more prior lower segment cesarean deliveries may be offered VBAC after counseling by a senior obstetrician, and this should include the risk of uterine rupture, maternal morbidity, and the individual likelihood of successful VBAC given a history of prior vaginal delivery. And the labor should be conducted in a center with suitable expertise and recourse to immediate surgical delivery. Next, these are important figures after 2 cesarean sections. The success rate of VBAC is 71.1%. The chances of uterine rupture is 1.36%, and chances of hysterectomy is 56 out of 10,000 compared to 19 out of 10,000 in case of previous one. Blood transfusion 2% in previous 2 as compared to 1.2% in case of previous 1 scar. Percentage risk of uterine rupture in planned VBAC 0.5%, previous 2 scars 0.9 to 1.8%, and previous uterine rupture 5.5%. And the previous classical scar, there is limited data about the exact percentage. Next, what factors increase the risk of uterine rupture? Short interdelivery interval, less than 12 months since last delivery, post-date pregnancy, maternal age of 40 years or more, obesity, lower pre-labor Bishop score, or macrosomia. Next, what are the overall aims of antenatal counseling? First is antenatal counseling should be documented in the notes. Next, final decision for the mode of birth should be agreed upon by the woman, members of the maternity team before the planned date of delivery. Third thing is when the date for the elective repeat is being arranged, a plan for the event of labor starting before the scheduled date should be documented in the notes. And the routine use of VBAC checklist during antenatal counseling should be considered as it would ensure informed consent, shared decision making in women undergoing VBAC. Because 10% of the women planned for elective repeat cesarean section go into labor before 39 weeks of gestation. Next, what is the likelihood of VBAC success? Women should be informed that the success rate of planned VBAC is 72 to 75%. and women with one or more previous vaginal births should be informed that previous vaginal delivery, particularly previous VBAC, is single best predictor for successful VBAC and associated with planned VBAC success rate of 85 to 90%. And previous vaginal delivery is also independently associated with reduced risk of uterine rupture. Next, these are the factors that are associated with the success of VBAC. Greater maternal height, maternal age less than 40 years, BMI less than 30, gestational age less than 40 weeks, and infant birth weight less than 4 kg. Now, what delivery setting is appropriate for conducting VBAC? Women should be advised that the planned VBAC should be conducted in a suitably staffed, equipped delivery suite with continuous intrapartum care, monitoring with resources available for immediate cesarean delivery, advanced neonatal resuscitation, and women with an unplanned labor history of previous cesarean delivery should have a discussion with experienced obstetrician to determine the feasibility of VBAC. Next, epidural analgesia. Epidural analgesia is not contraindicated in planned VBAC, although an increasing requirement for pain relief in labor should raise awareness of the possibility of an impending uterine rupture. Next, women should be advised to have continuous electronic fetal monitoring for the duration of planned VBAC, commencing at the onset of regular uterine contractions. Now, how should women with a previous cesarean birth be advised in relation to induction or augmentation of labor? Then women should be informed that there is 2 to 3-fold increased risk of uterine rupture and around 1.5-fold increased risk of cesarean delivery in induced or augmented labor compared with the spontaneous VBAC labor. A senior obstetrician should discuss the following with the woman: the decision to induce labor, the proposed method of induction, the decision to augment labor with oxytocin, and the time intervals for serial vaginal examinations, and the selected parameters of progress that would necessitate discontinuing VBAC. Clinicians should be aware that induction of labor using mechanical methods, amniotomy or Foley catheters, is associated with lower risk of scar rupture compared with induction using prostaglandins. Now, what elements are involved in perioperative, intraoperative and postoperative care for elective repeat cesarean? Elective repeat cesarean delivery should be conducted after 39 weeks of gestation. Antibiotics should be administered before making the skin incision in women undergoing elective repeat cesarean. All women undergoing elective repeat should receive thromboprophylaxis according to the existing RCOG guidelines. Early recognition of placenta previa, adopting a multidisciplinary approach, and informed consent are important considerations in the management of women with placenta previa and previous cesarean delivery. Next, this is how should women in special circumstances be cared for. Clinicians should be aware that there is uncertainty about the safety and efficacy of planned VBAC in pregnancies that are complicated by post-date, twin gestation, fetal macrosomia, antepartum stillbirth, maternal age of 40 years or more. Hence, a cautious approach is advised if VBAC is being considered in such circumstances. Women who are preterm and considering the option for birth after a previous cesarean delivery should be informed that planned preterm VBAC has similar success rate to planned term VBAC, but with a low risk of uterine rupture. Now, clinical features associated with uterine scar rupture. These include abnormal CTG, severe abdominal pain, especially if persisting between contractions, acute onset scar tenderness, abnormal vaginal bleeding, hematuria, cessation of previously efficient uterine activity, maternal tachycardia, hypotension, fainting, shock, loss of sensation of the presenting part, change in abdominal contour and inability to pick up fetal heart rate at the old transducer site. These are few percentages or difference between VBAC and elective repeat cesarean. Uterine rupture chances in VBAC is 0.5%, but in elective repeat is less than 0.02%. Blood transfusion in VBAC 2%, elective repeat 1%. Maternal mortality 4 out of 100,000 in VBAC, and elective repeat it is 13 out of 100,000. Now, the respiratory morbidity in VBAC is 2 to 3%, while in elective repeat it is 4 to 6%. Stillbirth, in VBAC 10 out of 10,000, and in elective repeat it is not applicable. Hypoxic ischemic encephalopathy, in VBAC its percentage is 8 out of 10,000, while in elective repeat it is less than 1 out of 10,000. Now, the risk of placenta previa and the risk of placenta accreta in previous 1, 2 and 3 scars. In previous 1 C-section, the risk of placenta previa is 1% and the risk of placenta accreta is 11 to 14%. In previous 2 scars, risk of placenta previa is 1.7% and the risk of placenta accreta is 23 to 40%. Previous 3 scars, the risk of placenta previa is 2.8% and risk of placenta accreta is 67%. This is the protocol that we have made for our department for the vaginal VBAC trial patients.
Actually, we have made the finalize the protocol guidelines.